Hello everyone in CardioMinds channel, and today we are having our last video in the topic of guidelines of cardiovascular disease prevention, and today we are discussing specific cardiovascular diseases. In this video we are targeting the ESC recommendation in relation to the cardiovascular prevention for specific cardiovascular disease, including coronary artery disease, cerebrovascular disease, lower extremity arterial disease, beside chronic kidney disease, and atrial fibrillation. As the heart failure have specific guidelines in 2021, so it will be discussed later in separate videos in order to discuss their diagnosis and management. Let's start with coronary artery disease. We already know from the video of antithrombotic therapy that aspirin has class 1 recommendation for secondary prevention in patients with previous MI or revascularization, and it has class 2B for patients without a history of MI or revascularization, but they have definitive evidence of coronary artery disease on imaging, for example, CT coronaries. We also know that the duration for dual antiplatelet therapy following acute coronary syndrome is for 12 months, while it is 6 months for elective PCI for chronic coronary syndrome, and here clopidogrel is recommended, unless there is a recommendation for a shorter duration due to high bleeding risk. We also mentioned that we can add a second antithrombotic medication to aspirin, for example P2Y12 inhibitor or low-dose Rivaroxaban 2.5 mg twice per day for long-term secondary prevention in patients with high risk of ischemic event without high bleeding risk, and this recommendation descends from 2A to 2B in patients with moderate risk of ischemic events. We can add today that RAS blockers like ACE inhibitors or ARBs are recommended if the patient is having associating heart failure, hypertension, or diabetes, and beta blockers are recommended if the patient is having LV dysfunction or systolic heart failure. So these medications are not routine for any patient with coronary artery disease. They have specific indications, and of course the target LDL in those patients is less than 55 mg per deciliter and a 50% baseline reduction, and this is the same recommendation as in any patient with established atherosclerotic cardiovascular disease. Let's now move to the cerebrovascular disease. We also mentioned in the antithrombotic therapy that antiplatelet has a class 1 recommendation for patients with non-cardioembolic stroke or TIA, and anticoagulant is recommended in patients with cardioembolic stroke or TIA. And also we mentioned that the long-term prevention for any patient with non-cardioembolic stroke is using aspirin only, or aspirin and dipyridamole, or clopidogrel alone, and this is a class 1 recommendation. But in the first 3 weeks after the acute event, we can use aspirin and clopidogrel or aspirin and ticagrelor, and so dual antiplatelet therapy is usually recommended in patients with minor ischemic stroke or TIA just for the first 3 weeks. And this drags us to the THALES trial, which studied the effect of ticagrelor added to aspirin in patients with non-cardioembolic, non-severe ischemic stroke or high-risk TIA, as the patient were randomized either to ticagrelor added to aspirin or placebo added to aspirin for 30 days, started within 24 hours of symptom onset, and the result that there was greater absolute risk reduction of stroke or mortality at 30 days in patients with ipsilateral carotid stenosis, while this benefit didn't appear in patients without carotid stenosis, and there was no increase in risk of severe bleeding. That's why ticagrelor can be added to aspirin for the first 3 weeks as evidenced by the guidelines. And we should not forget that there is a class 1 recommendation for improvement of lifestyle beside pharmacotherapy in patients with cerebrovascular events, and if a patient with stroke or TIA having blood pressure more than 140/90, at the time we need to lower the blood pressure, but to be cautious against rapid lowering of the blood pressure, which may result in cerebral hypoperfusion. And again, reminding ourselves that the most valid indication for prescribing oral anticoagulant is for just cardioembolic stroke or TIA, not for non-cardioembolic stroke. Now let's move to lower extremity arterial disease, which is sometimes defined as ankle brachial index less than or equal 0.9. Let's first emphasize some facts that there is a famous theory that if the large vessel is affected, there is a high probability for the small vessel to be affected as well. That's why patients with lower extremity arterial disease have a high probability to develop coronary artery disease. So patients with symptomatic or asymptomatic lower extremity disease is associated with double to near risk of coronary events, cardiovascular and total mortality, and within 5 years of lower extremity arterial disease diagnosis, 20% may develop MI or stroke with a mortality reaching 10 to 15%. So those patients should be screened also for coronary and cerebrovascular disease. So we have nearly the same recommendation as class 1 for smoking cessation, for healthy diet and physical exercise, for supervised exercise training, as most of those patients have intermittent claudication limiting their exercise capacity, so supervised training would be better, but if it is not available, we can go for non-supervised exercise training. And there is also class 1 recommendation for strict glycemic control to prevent progression, and if they are hypertensive, class 2A to choose ACE inhibitors or ARBs, and we can choose calcium channel blockers in Black or Afro-American patients. Regarding antithrombotic therapy, we mentioned before that antiplatelet has class 1 recommendation in patients with symptomatic lower extremity disease, and if the patient is diabetic and have chronic symptomatic disease without high bleeding risk, we can combine low-dose Rivaroxaban with aspirin, and this is class 2B, and we remember the COMPASS trial, which studied low-dose Rivaroxaban plus aspirin in patients with ankle brachial index less than 0.9, and this reduced atherosclerotic cardiovascular events and also major adverse limb events like amputation, but there was a higher risk of major bleeding, so the evidence for this practice is not strong enough. So far, the optimal strategy for antiplatelet is still unclear in patients with lower extremity disease, and dual antiplatelet therapy is recommended after percutaneous intervention just for 1 month, regardless of stent type, and antiplatelet therapy has no evidence so far in asymptomatic patients who have low ankle brachial index without any symptoms. Regarding statins, of course, they can cause modest improvements in walking distance due to their plaque stabilizing effect via the pleiotropic effect, which can lower the risk of adverse limb events, and the primary target to reach target LDL less than 70 with at least 50% reduction of the baseline, and then we are having a secondary target to reach less than 55 mg per deciliter as in any patient with established cardiovascular disease. And we should remind ourselves that beta blockers are not contraindicated in mild to moderate disease as they don't affect walking capacity. So we need to remove this idea that beta blockers are contraindicated due to triggering vasospasm. But sometimes they should be carefully considered in critical lower limb ischemia as it may increase risk, but in general they reduce coronary events and adverse limb events. We can't speak about cardiovascular disease without mentioning the chronic kidney disease, as we have some facts that the severe CKD is associated with very high risk of cardiovascular disease, and so it is considered a coronary artery disease risk equivalent. And we have discussed this before in the video of risk stratification. And in patients with end-stage renal disease, acute coronary syndrome may have a typical presentation like by angina equivalent, and there are some hemodialysis specific syndrome like intradialysis hypotension and myocardial stunning, which may complicate treatment and affect your choice for the optimal medication, and so modifying the outcomes for the patient. That's why CKD is usually associated with the cardiovascular diseases when we are discussing them. So there is a class 1 recommendation that all CKD patients with or without diabetes should be screened for cardiovascular disease and for kidney disease progression, including monitoring of albuminuria. And those patients, when they are diabetic or hypertensive or having albuminuria, they should receive RAS blocker like ACE inhibitor or angiotensin receptor blocker, and should be titrated to the highest dose because they are the best choice for hypertension, for reducing albuminuria, and for reducing the complication of diabetes. So please don't deprive the CKD patient from the benefit of RAS blockers, and SGLT2 inhibitors has a class 2A to control and prevent renal deterioration and reduce mortality. So also don't deprive CKD patient from the benefit of SGLT2 inhibitors. And the big no for CKD is for the combination of ACE inhibitors and ARBs, whatever the reason. Even in patients with heavy proteinuria, just one of them can be used. Atrial fibrillation is one of the common comorbidities to associate atherosclerotic cardiovascular disease, and that's why there are some specific recommendations in the guidelines of cardiovascular prevention concerning AF. So there is a class 1 to identify and manage any risk factors or concomitant disease which may be associated with higher risk of atrial fibrillation, modify any unhealthy lifestyle which may increase the burden of AF, and try to advise the patient for good blood pressure control in order to reduce recurrence and risk of stroke. Also, there is a class 2A for obese patient to advise for weight loss, as obesity is associated with higher risk of atrial fibrillation and also higher risk of recurrence and symptoms, and advice to avoid alcohol excess as it is associated with increased risk of atrial fibrillation and increased burden of symptoms, and also physical exercise should be considered to prevent incidence and recurrence of atrial fibrillation, except the excessive endurance exercise which may promote atrial fibrillation. And there is a class 2B for optimal management of obstructive sleep apnea, which is one of the famous conditions to be associated with increased risk of AF incidence, progression, and recurrence. So if we need to summarize this recommendation, what can prevent atrial fibrillation and reduce AF burden? Control of major risk factors, optimal management of comorbidities, healthy lifestyle, weight loss, optimal blood pressure control, avoid alcohol excess, regular physical exercise except endurance exercise, and optimal management of obstructive sleep apnea. The last topic that we are going to discuss today is the famous terminology which appeared in the recent years, which is multimorbidity. It concerns patients with multiple comorbidities, either cardiovascular or non-cardiovascular comorbidities. Cardiovascular comorbidities like hypertension, hyperlipidemia, coronary artery disease, and diabetes are more common in males, while non-cardiovascular like osteoarthritis, back and neck problems, COPD, low vision are more common in females. The challenge in these cases is that there are disease-disease interaction, disease-drug interaction, and drug-drug interactions, because we are speaking about a patient with multiple disease, and each doctor wants to have optimal management for his disease. So each one of them may affect the prognosis of the other or limits the introduction of specific medication which may have hazardous effect for another disease. And so there are some concerns that the care for multimorbid cardiovascular patient is given by multiple providers from multiple specialties. Each one is working in a remote island from the others, and so this complicates decision making and complicates the compliance to treatments. And also the multimorbid cardiovascular patients are usually underrepresented in most clinical trials that underlie the guidelines, so there are no specific recommendations for them. So the guidelines of the cardiovascular prevention recommend to shift from disease-focused care to patient-centered care. So instead of just asking the patient what is the matter, I should ask him what matters to you, in order to see what are the patient preference which can affect and increase the compliance rate. So I should pay attention to the patient's preference. I should consider the overall prognosis, including life expectancy, functional status, quality of life, and the clinical feasibility of this medication, of this intervention, taking into account the compliance to treatment, its adverse effects, and also the cost when I'm trying to push or optimize the medication. And I should try to stop any non-essential medication to reduce the risk of polypharmacy and the risk of non-compliance and depression due to taking multiple medications, and multidisciplinary team between the specialties in charge of the patient treatment like cardiology, nephrology, endocrinology, orthopedic, neurosurgery should all cooperate and discuss the patient case in order to see what is the best of the patient, instead that each one is looking for the optimal treatment regardless of other comorbidities. So at the end of this video, our take-home message today is that the general recommendations are nearly similar for all cardiovascular diseases regarding blood pressure, lipids, and diabetes, with some differences regarding the appropriate antithrombotic therapy, and so this raises attention for meticulous history taking and screening for other cardiovascular disease or other vascular beds in presence of one of them to select the appropriate antithrombotic therapy. Thank you very much for watching this video, and so we have reached the end of the topic of cardiovascular disease prevention, and soon we are discussing a new guidelines in a new series of videos on CardioMinds.